All right, this is Serve and Andy take five.
There we
But
go.
you're only going to see this take on here. But I have Andrew Baker. I know you like to be called Andy, so we'll call you Andy.
Mhm. Sure.
You are a oral maxillofacial surgeon, right?
Yes.
Right. Yeah. So you did all that, and then, but not only that, you actually did a fellowship. So kind of tell us your path to dental school and kind of where you're. Let's do this. Let's start with where you're at now, so people know what you do, and then we can kind of want to talk to you about how you got into dental school and your path to where you are.
Sure. So I'm a board certified oral and maxillofacial surgeon. I practice in West Michigan with a group called Oral Surgery Associates of Lansing. I'm one of six, and three of us are fellowship trained, or we've done a little bit more training beyond residency.
A lot more.
And then we're all six of us are kind of dedicated to trying to treating the patients in our community and like the full scope of what oral and maxillofacial surgery has to offer. So it's a great mix. And then a term that I've heard recently is we have like a pracademics
I've never heard
practice.
that.
It's a
I heard you say it before. I've never heard that before. That's kind of cool. I like that. That makes sense.
yeah, yeah, we're trying to, I guess, do it all to a certain extent. I mean,
Yeah.
there are practicality issues that we can go over, but yeah, it's a pretty broad scope practice.
I mean, that's great. I mean, when you say full scope, just so people know, what you're trained in is cancer surgery, right? So oncologic surgery,
Yeah.
microvascular reconstruction, that sort of stuff. So someone comes in with a squamous cell on their tongue, they see
hmm
you, right?
hmm
And so not only you're not just doing the biopsy, you're doing the biopsy, then you're going through the treatment options. Is your practice hooking them up with oncology then and all that stuff if they don't have any connections? How do you guys manage all that?
Yeah, so I can actually use a patient I saw today as an
Yeah.
example. So, gentleman comes in with a sore on the tongue, exactly like you described from the
Yeah.
dentist, and it's been getting worse. And I saw them actually last week for their initial biopsy, concerned that it's a malignancy. And then the care of a cancer patient, even if you're in private practice or in academics, is multidisciplinary. They are
Yep.
part of an oncology team. And so, myself, as well as some of my partners, are members of the multidisciplinary head and neck cancer tumor board. And that consists of surgeons, both ENT, oral and maxillofacial surgeons, radiation oncologists, medical oncologists, speech language pathologists, care managers, the entire crew that's going to be navigating this patient's care. So
Yeah.
we plug them in to that team, get them set up with regard to their workup for surgery, which is
Yeah.
not only just surgical preparation, but staging them,
Yep.
and then you get them to the OR and make sure their post-operative care is also, which it could also involve like adjuvant therapy, radiation, chemotherapy is taken care of. The surgery with regard to these patients, while extensive, is just after a while, that's the easy part. What the patient is contributing in terms of their recovery and their surveillance. I'm married to these patients for a minimum of 5 years afterwards in terms of
Yeah.
watching them and helping them
Right.
navigate their reconstructive challenges.
No, I mean, that's a lot. Like, is it pretty much like a plug and play with your practice now? Like you can see these patients and you have a nice little system where you can kind of get them into the staging, the workup. You need a medical oncologist. You're going to might need a radiation specialist as well, right? All that stuff.
Yeah, I mean, it is somewhat systemized. While everybody is an individual, there are national guidelines on these subjects, and
Yeah.
we can follow those pretty easily. One of the biggest assets of our care is, one of my office managers, Julie, who is a wizard when it comes to navigating some of the insurance issues, placing orders, getting patients to like a surgical optimization appointment preoperatively. This is a team sport for sure. But as you know, that's the case when it comes to not just oncology, but oral surgery in general. We're constantly collaborating with our dental colleagues, our medical colleagues, and other members of the community. So, but yeah, it's we have a nice system, I guess. It's taken a little
No,
while to
you
establish.
definitely need that, especially if you're in private practice. Like you said, academics, like trying to treat these cases without residents. And sometimes you may or may not have people helping you out, but that's not
Mhm.
always a given, I assume. How'd you
Yeah.
decide about cancer? Like, you were like in high school, college, or like, I want to do cancer surgery? Like, what happened? Because you had to go
Uh,
to dental school first, you
Yeah,
know?
I was in high school. I attended this National Youth Symposium at Georgetown where I got exposed to surgery. It was like a pre-med. I mean, I was a high school senior or
Yeah,
something
you're
along
really
those
in it then.
lines.
Yeah.
And then I was just like, oh, I'll be a surgeon. And that seems good to me. My mom, who's a nurse, kind of plugged me in with some local surgeons. I shadowed them in the OR. And then in college, I was on the pre-med route. I considered doing some philosophy. I got pretty interested in that. And my dad, who's a dentist, suggested that I consider dentistry. He worked for the VA hospital, just recently retired, did a
Nice.
lot of bread and butter dentistry, a lot of like dental extractions. And so I thought, okay, actually, dentistry is the best fit for me. It's a great fit of both worlds. I can still philosophize in my free time, so to speak.
Do what you
But
want in
it
your
was
free time. Yeah.
yeah. So, but it was in the very early stages of dental school that I kind of got exposed to this expanded scope or just broader
Yeah.
scope oral surgery at the University of Michigan. I was rooming with a resident who was just looking to find a dental student to rent a room in his apartment. And he said, do you want to come to the OR with me? Right. This was like 2 days before classes started. I had just moved from
So
West.
before you got to dental school, essentially, you're seeing this big
Yeah.
case.
Yeah, I'm from Western Pennsylvania. I went to Ann Arbor for at the University of Michigan. I had just moved in, and he's like, "You want to come to the OR with me?" Got me a pair of scrubs, and I just kind of followed his footsteps. And it was a massive self-inflicted gunshot wound where they were doing this kind of free flap reconstruction, kind of a double free flap, so a really huge case. And at that point, I was kind of hooked. I really didn't know what I was seeing, but was very intrigued and
That's
kind of made it my
insane.
plan. Yeah.
I'm trying to picture myself way back then, like seeing a case like that, like in college, like I wasn't really ready for that. Like, I mean, I don't think I would freak out, but I would be in such awe of something like that at that point in my life. And some people are like,
Yeah.
would freak out and faint. And some people go the other way, like you, are like, oh, this is so cool. I want to do this,
I was just like, I just couldn't believe it. And, funny enough, our first class in dental school was anatomy. And
Yeah.
so that just like really, really, really motivated me. Like, I think a lot of dental students are kind of gunners anyways. They want to really study, but I was just like, I need to understand this so
Yeah.
that maybe one day I could do that. And
Yeah.
it was really fun.
No, that's awesome. Yeah, I love this stuff too. Essentially, like through college, I did anatomy classes. We had cadavers at our college, so I did those, and I was a student assistant for those. I just stayed on board with all that stuff. In dental school, they make you do anatomy again and bio, all this stuff, right? But that's awesome. So 4 years of dental school, and you're like, I want to do in dental school pretty much the whole way. Then you're probably like, I want to do oral surgery, right? Or were you
Yeah.
considering anything else?
No, I just really fell in love with oral surgery. To be honest, I probably wouldn't have been the best dentist. Like by the
Yeah.
time I was like a second and certainly a third and fourth year, I was doing whatever dental school classes I needed to, and then I was sneaking away and going to the hospital. And I was
What?
just
That's awesome.
working. Yeah, I was just kind of going on every morning, rounding with the residents, trying to get into the OR when I could,
You would
shadowing,
just do this on your
just trying to
own.
be helpful. Yeah, there was a group of us, and two of whom are now my partners in our practice, all of whom trained at Michigan. We
Yeah.
we just were really dedicated and really obsessed. We just wanted to do oral surgery, and the program is so welcoming for us to do that. So if you
That's
showed up and
nice.
put the time in, you got to progressively get a little
As
bit
long as you're not
more
annoying.
involved.
As long as you're not annoying.
Don't
Don't
be
be
annoying.
annoying.
Don't be annoying.
Don't be that guy.
Yeah.
Yeah, I do as affiliate faculty at the University of Washington Dental School. I've been doing that with the third and fourth year dental students. I've been doing that for a while now,
Hmm.
years, and so it's always fun to see. And you can always tell, like some students, they're just doing the basics just to get through the rotation of oral surgery, and some are
Hmm.
just gunners. They're just there, they're asking
Hmm.
questions. What can they do to do this, that, and so like there's definitely, you can definitely tell who's into it, and who's not.
Hmm.
But you don't want to be that annoying guy either, or girl, but.
Got to read the
Always
room.
just, yeah, you gotta do that. You gotta do that. You can do too much, and you don't want to do that either. But that's awesome. So you were pretty much OMFS all the way, and you're like, yeah, I want to do dual degree. I think because I think it probably keeps your options open for fellowship. Probably, I would
Hmm.
assume. I know you can do them, at any level. But I think if you're going into cancer, especially politically in a lot of places, it would probably make more sense if you had the option to do it.
Yeah, I think it's a very individual decision. There are plenty of examples of outstanding, kind of boundary pushing, a single degree surgeons doing
Yeah.
oncology and doing the other kind of
Even
broader scope
aesthetics,
parts of
even
oral surgery.
aesthetics, and yeah, right, for sure, for sure.
But
But yeah,
for
so
me, it
it's
was
two
the
extra
right
years.
choice.
Yeah, I liked it. For me, I only applied to the programs that had that just because I didn't know what I wanted to do. And I was actually thinking oncology through residency, but then I was thinking the
Okay.
other way. I was thinking I'm going to do it as an ENT. So
I
even
see.
after medical school, I actually secretly went through the match program for ENT and I
Oh
interviewed
yeah.
at some places. And then, life kind of happened and I just decided, after a couple interviews, I'm like, you know what, I'm just going to stick it out in oral surgery and just do that. But I was actually considering it, but I was going to do it through the ENT.
I see.
But I ended up just doing, residency and no fellowship or anything. So I'm like, I'm happy, but I mean, I actually thought of it too. And I kind of went through the motions for a while, then decided
Sure.
eventually no. But yeah, because I just thought politically it might be easier. How do you think about that? Like, so like with
Yeah.
ENT and oral surgery competing, and even plastics, I guess, for these sort of cases, how does that work? Does it matter anymore? Or was that just used to be like how it was, but now people don't even want to do it because it's too hard? I don't know, time consuming.
I think in like your major academic institutions, there is a little bit of a political fight. It just depends upon the institution. So at
Yeah,
Michigan, I feel like there was competition, although, both oral surgery and ENT had really booming, very busy oncology practices.
yeah,
When I went out to Portland for my fellowship, really it was oral surgery doing the bulk of oncology and from skull base down to clavicle.
yeah.
So it's a geographic thing, it's a referral pattern thing. In private practice, I find that it is very much a meritocracy. There are problems, and can you solve them? And I work really closely with some of the ENTs on the tumor board at the hospital I work with. I refer patients to them. Sometimes they refer patients to me. It's a
Yeah.
very collaborative, very
As it should be,
collegial
really.
environment.
Yeah,
Yeah,
that's
because
awesome.
everybody has a little bit to bring to the complex puzzle that is head and neck reconstruction.
Yeah.
It's a super complicated area, limited anatomy, everything's precious. So what you might be able to bring in terms of the dental reconstruction, that is valuable to your ENT colleagues, and what they may be able to bring from a different perspective is very valuable to me. I find that it's not really a political issue. Also, we're not talking about that rare of a disease process. There's about 50 to 60,000 cases in the United States every year. There's not a shortage of this stuff going on. These
There's
people
enough to
need
go around.
treatment.
There's enough to
Yeah.
go around. Yeah, especially with vaping and all the stuff. But yeah, so yeah, politically at the time, like it was. What's funny is like when I was in residency, like I'm way older than you, so this is like the 2000s, right? And like back then, when you got out of residency, like it was like a badge of honor to be able to admit your own patients and do
Oh.
all the things in the hospital yourself, kind of before hospitalists really got running, right? And
Mhm.
so like that's when I first started practicing. Like I would admit my own patients and do all the things, but it's kind of hard to manage that when you're in private practice, really. Like if someone calls
Mhm.
you on the floor with chest pain, like what are you going to run over there after your wisdom tooth case and then like check on them and then go back to your
Mhm.
office? You really need, what do you call it? Hospitalists now. Like, and so
Mhm.
now like, I don't even want to admit anyone. I'm like, is a hospitalist going to admit them because then they can consult me. That's easier.
Sure.
So I think that's how it is now, which is also very nice, right? That's how you guys have it
Yeah.
set up.
Yes. So, like, whenever I'm on call, we typically are admitting either to an observation unit, a trauma team, depending upon the pathology, or a hospitalist,
Yeah.
because at least in our setup, it would just be impossible for me
Yeah.
to be managing a bunch of patients on the floor while seeing patients in clinic, while
Right.
operating. I
Yeah.
work 5 days a week. Plus, if I'm on call, I'm working, 7 days a week.
Yeah.
It's clinic 4 of those days and OR one of those days. And it
Nice.
varies a little bit depending upon the week. But
Right.
I also had the real privilege to work with some residents the last couple years. So that's kind of a fluid sort of thing, but that has been tremendously beneficial. And it's kind of like the next phase of learning. As you're working with students and residents, you in residency, you kind of learn how to do an operation. In fellowship or private practice, you really start as you're doing it independently. That's a whole nother level of ownership. Well,
Yeah.
now as I'm trying to teach it to young residents and stuff, I was like, whoa, I'm learning even more. It's exposing my own little holes in my knowledge.
Yeah, no, it's always good. Like even taking photos and pictures of your work also
Hmm.
helps me. Like it's like I learn as I go. Like, oh, I probably could have done that a different way, or maybe I'll try this way next time. Like looking at your own photos, I feel like your memory is also always like better than what if you feel like it's better than what it probably really was. And so like the photos and videos really help to like, oh yeah, yeah, that's what it
Have you
was.
have you found that with your head cam?
Yeah.
Because like I'll watch when we do it, I'm like, I could do that way better. I could do that a little bit more efficiently.
Yeah.
And it's like athletes are doing that, right? They're watching film,
Their
they're
golf
trying to get
swing, they're
better.
watching their everything,
Yeah.
right? Everything like helps. I
I
agree.
think it's I think it's really helped me become a little bit more efficient, a little bit more honed watching some of the surgeries. And, I think I'm using the same head cam that you are.
Yeah, we have
I'm
the
more
same head
new
cam.
to, yeah, more
Yeah.
new. I love it for that reason.
Yeah, it's interesting. Just it's a whole new way. Like you have to hold your head a little differently for the shots, and like as you're going, you learn. Like when you review your footage, you're like, oh, that was out of frame. That was, I got to hold my head like this better, or not move my head so much. So you're the surgeon. A lot of times you're the anesthesia person, and you're like the cinematographer and the director of what you're doing. So there's a lot of stuff you're doing at the same time when you're wearing one of those
Right.
things. Trying to get decent shots, I guess, of your work. So what was in residency like? What was your like longest case? I have like, can you
26
remember like in
hours.
the OR? 26 hours. Oh my God. Yeah, I always like, I don't think we ever had one that long. I think one lasted like 18 or 19 hours though. What was that case? That sounds crazy.
That was one of these double free flaps. So
Yeah.
that may have been a gunshot as well.
Yeah.
It was one where you have this, terrible defect without a lot of relevant anatomy. You're trying to lay the bony foundation, usually in the form of like a fibula or a scapula or something like that. In this case, it was the fibula. And then overlaying that with even more soft tissue to reconstruct some big avulsive skin injury.
Yeah.
At the time, with that particular case, it's not like I was actively
Yeah.
involved in it. It was the fellows and the attending, but I'm not going to show weakness. I'm not going to
No.
scrub out before they scrub out,
Yeah, you can't. I mean, yeah, there's unwritten rules, man. Um, so 26 hours is ridiculous. The longest case I was ever a part of, I was actually an intern. Like, it wasn't even my case. But like you, I was like trying to be in there as much as I can. But I don't know how the chief and the attending did it for that long, and they took some breaks here and there, and one took over. But it was like 18, 19 hours. It was
Yeah.
like rib grafts, all those things, both joints, and blah 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 blah. It
I
was a
will
long
tell
one.
you, I don't do that these days. So,
Yeah.
like everything that when it's a big case, so an ablative combined with a reconstruction in the microvascular, I'm typically doing this in a two-team approach. So, one of my partners is coming in with me. Somebody's working at the head, removing the cancer.
Right.
Somebody is at the leg or the arm or the shoulder, wherever we're harvesting the flap from. We're
Yeah.
combining, and we can get these done much more efficiently.
That's
'Cause
amazing.
That is
Yeah.
that is not sustainable to do operate
No.
that long.
Yeah, then assuming you don't have to flip the patient or do anything funny. But
Mhm.
yeah, so that's crazy. That's a long case. Yeah. But what about fellowship? Like, what were those cases like? And what was your fellowship like? You did a 2-year fellowship. That's a long one.
Yeah, so I went out from the University of Michigan for residency and went out to Portland, Oregon to Providence Cancer Institute with the Head and Neck Surgical Associates practice. And
Yeah.
it's a 2-year fellowship. The first year, you're really honing your skills in ablative surgery. That's removing the cancer, neck dissections, things along those lines. You're also, and one of the most, I mean, obviously surgery is very important, but when it comes to these oncology patients, it's the pre and the post-operative patient. So you're on primary call taking care of these patients. That's one of the biggest learning experiences that you're
Huh.
going to get out there. And then the second year, you're focusing on the reconstructive side of things, which is primarily free tissue transfer. That's taking one part of the body and moving it up to the head and neck, and then
Yeah.
anastomosing the vessels under a microscope to vessels in the neck. And so that was a really tremendous experience. Some of my mentors out there, Sheesh Patel, Alan Chang, Brian Bell, and Babar Khatib, they're amazing surgeons. I was really fortunate to get to train with them.
No, that's a great program, and they've been doing that stuff for a long time. Even when I was interviewing for residency, like Dr. Dirks and Dr. Potter at the time were
Yep.
doing a ton of that stuff in Oregon. And I know the chiefs were involved a little bit, but they did have fellows, which was nice, right? So it's a 2-year program. Are all the oncology fellowships 2 years?
They are not. There's a few that are remaining that are a year, I think, like Jacksonville, University of
Yeah.
Michigan. Theoretically, we have a fellowship that's opening up that would be a 1-year that's going to be run by one of my partners, Dr. Justine Moe, who is actually one
That
of my
is
bosses at the
awesome.
University of Michigan.
And now she's
So-
one of your partners. That's so cool.
Yeah, no.
That is
So,
awesome.
but
So you guys are going
that's
to be
kind of in the
having a
works.
fellow. Yeah. That's
It's in the
amazing,
works,
man.
yeah.
That's amazing. That's a lot to set up, and get that
Mhm.
accredited and all that stuff. And good for you guys, man. That's
Mhm.
awesome. So it's like a 1 year spot, maybe?
It's going to be a 1 year spot. I mean, we don't have a fellow currently, but it's in the
Yeah.
works. Dr. Mo was, heavily involved in the development of the fellows at the University of Michigan. She'll be taking
Yeah.
that skill set to us in our practice, and
That
she's
is that
tremendous
is
to work with.
that's awesome, man. I mean, you guys have 3 surgeons that are trained in that stuff, and that's awesome, and 6 surgeons in your practice. So I was just wondering, like, as far as like pathology, you had mentioned before, like you treat most oral cavity stuff essentially, right? So buccal
Hmm.
mucosa lesions. Do you do floor of mouth?
Hmm.
How far back in the
Yeah,
pharynx?
I pretty much limit my scope to oral cavity. And so
Yeah.
when we're talking about pathology that's common in like oral cancer in general, you want to distinguish between oropharynx and
Right.
oral cavity. In fellowship, those guys in Providence Cancer Institute, Head and Neck Surgical Associates, they were
Don't mind
doing
this guy.
skull base, very cute, skull base to
All
clavicle,
right.
robotic surgery for back of the throat and oropharyngeal cancer. At this point, I'm doing mostly oral cavity cancers, which is typically squamous cells, some
Yeah.
parotid stuff, and then whatever comes in here or out. I don't do thyroid or larynx at this point. I refer those to some of my ENT
Yeah.
colleagues, although
Yeah.
you're kind of trained. But so yeah, I guess most common sites are tongue, floor of mouth. The body doesn't distinguish, doesn't read a textbook. You can get buccal cavity, maxilla, gingival lesions, but we want to distinguish between the oropharynx because HPV becomes a big part of this, and that really is a fork in the road when it comes to treatment options for patients. So I don't know, we can talk a little
HPV
bit.
cancer is crazy. Like I've seen some, I don't treat them, but obviously I've seen them and even biopsy things. But
Mhm.
HPV carcinoma is so crazy. It looks so scary. And then you give them their treatment and they don't necessarily need surgery. Is that true?
Correct.
Yeah.
That's true. That's true. When it comes to squamous cell carcinomas or oral squamous cell carcinomas, you want to distinguish between tonsillar, base of tongue, which 70% of are HPV related, versus mouth or oral cavity cancers, tongue, floor of mouth, buccal mucosa. They may or may not have HPV positivity on testing, but it's not clear that that's actually driving the disease.
Right.
These oral pharynx HPV positive patients contrast sharply from their HPV negative oral pharynx or oral cavity cancers. They're typically younger. They don't have traditional risk factors like smoking or
Right.
alcohol, and they are much more amenable to treatment. So there's lots of studies going on right now to try to de-escalate their therapy. Way back when we were doing these radical resections of the back of the throat, that was replaced by chemo and radiation.
Yeah.
And then even more recently, TORS or transoral robotic surgery has come into play. But the idea is try to minimize the morbidity to the patient, preserving speech, swallow, and function, but don't compromise outcomes. But you're absolutely right. These patients typically do quite well.
What's the advantages of the robotic surgery for if you have that or not for those cases?
So before some of these robotic, developments, you would have to do what's called a lip split or mandibulotomy, a very morbid approach.
Yep.
Commonly to the residents known as the predator approach, trying to get access to the back of the throat.
Yeah, it just
That's
opens
a hard
up.
thing for
Yeah.
That's a hard thing for a patient to come by. With these articulating little arms, you're able to kind of get back there and do a resection of the tonsil for these smaller HPV-related oropharyngeal cancers like the T1 or small T2s. And speech swallow outcomes are great, and you might be able to spare that patient radiation or chemotherapy. Alternatively, sometimes they're just doing chemo rads in another de-escalated sort of fashion. It's a debate as to which is going to be better for that individual patient. Those are often discussions that are had during the tumor board, and you're just trying to minimize morbidity, maximize a great prognosis. And that contrasts sharply from the oral cavity, these tongue cancers, floor of mouth. Surgery is still the primary
The
treatment
main
option.
thing. Yeah. Yep.
Yeah.
Yeah. Yeah. So if you're going to get a cancer, you pretty much want it to be HPV related, so it's more curable, less surgery.
At least if it's in the oropharynx, right?
Right. Right.
And so that's a huge game changer that's been recent. And then we can talk. I mean, vaccination is becoming really popular. You've started to see a tremendous decrease in the
Does that
rate of
help with
cervical
cancer? HPV vaccination? Do you think that helps with oral
Yes.
cancer?
Yes, I do. There's a growing body of evidence to suggest that it's decreasing HPV-related infection. So in the cervical cancer world, there is decreasing rates thought to be related to vaccination.
Yeah.
There's a growing body of evidence that will suggest that it will be helpful for a cavity. HPV, right, is a DNA virus. There's like 200 strains of it, and maybe 13 or so are high risk. Notably, what at 13, 16,
Hey, 16, 18.
33, yeah, 16, 18, 33, 35. But there's like 13. What these vaccinations are targeting are these higher risk ones. It's ubiquitous. So almost all sexually active adults are exposed to HPV,
Yeah.
but it's necessary, but not sufficient for development of a cancer, meaning, nearly the entire adult population that's sexually active gets an exposure to HPV, but only a fraction of those patients will actually develop an HPV related cancer. If you're going to decrease the amount of HPV infection, hopefully you'll see a decrease in the cancers related to that.
What about this is interesting. People always ask me, or they have questions about like papillomas, right? People get
Yeah.
little papillomas in the mouth, on the palate or whatever, HPV related, but not really contagious, not to worry
Yeah.
about.
I don't worry about them. I don't tell them to modify their behavior significantly, perhaps HPV related. Now, most of the time when I'm biopsying these, we're not testing them for HPV, but it's not thought to be, a premalignant sort of thing, just a regular squamous papilloma.
Right. Yeah. So papillomas are really common little wispy things people get. Oftentimes they'll be excised or biopsied, and that's that. Generally, right? You don't have to worry about them too much. What do you recommend for people? And these are very common things you see at the dental office, and your dentist may refer them out or do them themselves. Like leukoplakia on the buccal mucosa. Let's say you do how do you treat those? Like you get a consult for a leukoplakia on the buccal mucosa. Like what do you do? What do you recommend? Like it's a diffuse kind of area, a white patch.
So almost always it's going to end with some sort of like incisional biopsy. But
Yeah.
here's the deal. Somebody comes in, they've got a white spot at some point in their mouth. Generally speaking, if it's homogeneous, it's not, red and white. If it's got well-defined borders, if it's very thin, there's a variety of things. It could be frictional keratosis. Could it be a lichen planus? Is it a dysplasia though? And you want to rule out the possibility of a precancerous lesion like a dysplasia or a even early stage cancer. And I typically am using like a punch biopsy or a 15 blade to take a small sample of it depending upon the size. But yeah, if you're in the dentist and you're seeing something like this it's kind of a little bit less concerning. The rule of thumb is typically give it 2 weeks or so.
Yeah, oral cavity stuff.
If it hasn't resolved, you're referring it typically to somebody like me or you for likely a biopsy.
Yeah. So let's say you do a biopsy on a white patch on the buccal mucosa and it comes back as moderate dysplasia. And it's like a diffuse lesion, maybe a couple centimeters on the cheek. Asymptomatic, nothing like that. What's your next step? Like monitor, rebiopsy, just a wide excision, laser? Like what do you like to do?
Yeah. I prefer surveillance a lot of the time, but let me back it up a little bit. Dysplasia, what is it? It's cellular or epithelial disorganization of tissues, and it's rated as mild, moderate, and severe. Typically, they all can have the potential to progress to a cancer, but
not necessarily in order. They can go whatever they want to do. Yeah.
Sure, but generally speaking, if it's severe, it's more concerning. When it comes to treatment options that are available for dysplasia, you have surgical excision, you have cryotherapy, you have laser ablation, a variety of other ones. The thing is, at least in my understanding of the literature, none of these modalities actually reduce the overall progression rate to a cancer. So I am typically observing my mild dysplasias unless it's something that's super easy and not very morbid to excise.
Right.
If you have a 5 millimeter by 5 millimeter little spot somewhere and you
get
can
rid of that
easily
thing.
excise it,
Yeah.
just get rid of it.
Yeah, I agree.
However, a lot of times, I think what you're referring to is multiple centimeters by multiple centimeters.
Yeah.
Excising that thing is a fairly morbid operation. And are you really benefiting the patient? That's up for debate, but I tend to take a sample of what I feel like is the most concerning area. If it comes back as mild dysplasia, I'm putting them on a surveillance protocol of some sort, whether or not that's 3 or 6 months for a while, and then sometimes we extend it. And I have conversations.
Hold on for 1 second. Hold on for 1 second.
No problem.
What's going on with my cat here? It's like crying. I gotta get him out of here.
No problem.
Okay. Observation.
Yeah, something like observation. If it's severe dysplasia, I'm typically going to take them to the operating room for an excision with a narrow margin. But why am
Okay.
I doing that? I'm not necessarily thinking I'm curing them of dysplasia. I'm trying to rule out that there's not a superficially invasive cancer somewhere in that swath of tissue,
Right.
because then they're going to need a real oncologic operation
Right.
with follow-up.
Yeah,
When
because
we get
what you did
to
at first was an incisional, and you just got a little piece of it. What you're trying to
correct,
make sure is you didn't miss like a spot somewhere else.
that could actually be invading.
Right. Right.
Because, right, the difference between severe dysplasia and cancer is only one cell layer thick with regard to the invasion of that basement membrane.
Yeah.
When it comes to moderate, we're having a nuanced conversation with the patient. Some patients you're going to find don't like the idea of anything that could be considered precancer in their mouth.
No.
You're offering those patients an excision, even skin grafting with something, or a laser ablation. I'm typically not laser ablating because I like the ability to take the tissue out and then send that to the pathologist so I
Yeah, that's
can,
the thing with laser. It's like you just burned it
it's gone.
basically. Yeah.
And I'm not saying that's wrong at all. Typically it heals back nicer, but the circumstances that led to the development of that dysplasia, which are within the host, are still
Still
there.
there. Yeah.
So like it doesn't necessarily mean that they're not going to get a dysplasia again. And I still think you need to arrange some sort of surveillance protocol for those patients.
That's an interesting concept. Like I didn't really think about it that way, or I'm sure a lot of people don't think about it that way. Like you remove a lesion like that, it's not cancer, it's pre-cancer possibly. Who knows?
Yeah,
But you remove it and people think that that's great and then they're done.
correct.
But what you're saying is not necessarily, because what
Correct.
led to that even forming is inside your body, whatever the physiology is still present. And
Sure.
it could reform, could do something, right?
Correct.
Yeah.
So like even like let's say I have a patient like the patient that I saw earlier today who is a heavy smoker, has a remote history of heavy alcohol use, and now has clearly a large like teeth squame on the side of his
Yeah.
tongue.
Right.
When I biopsy that area, I can tell him that it's very likely that your smoking and your alcohol consumption has contributed to the development of this, but there's nothing in that biopsy that says, yes, this is because you smoke and drank.
Right.
Because then the same patient comes in, let's say, unfortunately, they tend to be younger females on the side of the tongue with zero risk factors, but they've got the same lesion without any smoking. Their treatment is exactly the same. And there's nothing about the biopsy other than that's going to dictate a difference. And again, that differs from, I guess, the HPV population that we were talking about earlier.
Right.
But I guess what I'm saying is whatever circumstances led to the development of the dysplasia or the cancer, they're still present within that person. Now, that's not to say the patient who's smoking should not stop smoking
Yeah.
or
Right.
decrease it, or if they're drinking more than 4 alcoholic beverages a night, they should try to decrease that because that's not helping their case. But those changes, whether or not they're environmental or they're a problem with their immune system or whatever, because that's the other population you'll see patients with, somebody who's severely immunocompromised, they're more prone to getting cancer, not only in their mouth, but just everywhere. So you got to think about it like, why did this cancer develop? So surveillance is a huge part of what I do.
So you're seeing these patients back, like someone comes in with, let's say, and this is probably applicable to a lot of dentists because they'll refer patients out for biopsy, and let's say the surgeon or whoever biopsies it and comes back as dysplasia and they're done with them. Are you saying the surgeon should be following up with these patients like every 6 months, every year, just to see them in the office kind of thing, so they don't get lost? Or how do you guys usually
Yeah.
manage that?
Yeah. So unlike, our cancer patients where we do have more stringent guidelines, there's not as
I know,
obvious
right?
guidelines when
It's
it
kind of
comes
a
to
gray area
dysplasia.
there. Yeah. Yeah.
So this is just my personal practice, but it's not necessarily something that everyone should abide. But I tend to, like, let's say somebody has moderate dysplasia
Yeah.
and I have not excised it, but I've done the biopsies
Yeah.
in the areas that I feel like are most representative. I will follow them every 3 months, and then additional biopsies will be dictated by their subsequent clinical exams, or the patient may report to you changes. If
Right.
I typically am putting them on a regimen where they're looking at the spot in the mirror if it's easily visible and asking them to be aware of any new changes. Cancer is not always painful, but
No.
if a patient is perceiving something, I tend to be a little bit more prone to getting them back into clinic sooner. Now, if we've gone through a couple surveillance visits and nothing is changing, and a lot of these lesions they look a little bit more innocuous. They're not that big of a deal. I will probably extend them to every 6 months for a period of
Hmm.
time, and then I'll usually call the referral. Then the best diagnosers of early stage cancers or these dysplasias are dentists and
Hygienists.
hygienists.
Yeah, I know. I've
Hygienists are
got a lot
great.
of, yeah, they were really good at that.
So
I
if they
agree.
were confident enough to kind of find this, little lesion early enough, I'm typically calling their office and saying, "Hey, I've seen them now for a period of time and doesn't nothing seems to be changing. I'd recommend just following up during your normally scheduled hygiene checks. And if
Right.
you're ever concerned, get them right back to me. We'll
No, that's
reevaluate."
That's awesome. I mean, a lot of times that does happen. Like, follow up with your dentist, normal checks, anything changes, come on back, or you definitely want, follow them up yourself, which is great. Yeah. So dysplasias are always tricky sometimes because there's different grades. You're usually doing incisional biopsy. You're not testing the whole thing. So, you still got to be aware of a bigger lesion there. What do you think about those Velscopes that dentists use? You know what I'm talking about? Those
Yeah,
little
I
lights.
I
Do
do
they
know.
really help?
I don't have any personal experience with them, and I don't
Yeah.
necessarily recommend their use, but it's not from a personal experience. I think the best resource that we have available in the dental professional is just a sound knowledge of what is normal and
Right.
what looks abnormal. There's, to my knowledge, in the literature, nothing better than that. You have a sound knowledge of I can like still hear one of my mentors at the University of Michigan quoting a famous head and neck surgeon from Sloan Kettering, Hayes Martin, saying you need to have a sound knowledge of disease and a reasonable index of suspicion. So if you're concerned about a spot on the mouth, and then you're looking at your Velscope and it says you should be concerned, yeah, you're referring them for a biopsy. If you're concerned about a spot in the mouth, but your Velscope says no need to biopsy, should
You
you?
should
I
still
don't know what
refer
to do
them.
with that. Yeah, I don't know what to do with that. Like, I'm a little bit less concerned because I go back to when I'm talking to some of my residents or people like that. Occasionally, you'll get these lesions like a verrucous carcinoma, which is a variant of a squamous cell carcinoma. You biopsy it, and they call no cancer, but clearly to you clinically, it looks concerning. I
Right.
tell them, don't trust your biopsy, trust your clinical exam. If you're worried about something, rebiopsy. Even like occasionally, you just have to take the patient to the operating room, provide the pathologist with the entire specimen, and then they call it cancer when they
Right.
actually can see the excised
All the
specimen.
layers. Yeah, that makes total sense.
But so I'm not trying to bash Velscos. I just
Yeah, I don't
don't
know. I mean, I
personally
sometimes you
use it.
get those little pictures. It's like they see it on a light, but then clinically you don't see anything. It's always
You know
like,
what we used
okay,
to
well,
what we used to use in residency as a
I
diagnostic adjunct was toluidine blue.
totally blue. Yeah, yeah,
So that's binding nucleic acid. Theoretically, these cancers should be more highly metabolically active.
yeah,
It's going to highlight an area where you've got more, nucleic acid available, and that might, in a patient with something like proliferative verrucous leukoplakia or just this wide swath of a
yeah.
change, and you're unsure where is the most concerning area, that might highlight an area to guide your biopsy, and it's really cheap.
It's super cheap.
So
Yeah, I know.
yeah,
Yeah. No, that makes sense. Those are fun to see. I've seen those cases too, where you put it on there and it shows you kind of this area of activity, and that you kind of use that to get your margins essentially, which is cool. That's awesome. So what about lichen planus? I know like for the most part, like lichen planus is like the reticular form is generally not concerning. It's that erosive, like kind of red spotty form that's more concerning, right?
sure. It's hard. My last reading of the literature is it's kind of like hard to know exactly what is the rate of transformation to a cancer. I think it's, in all my reading, much less than 5%. I've seen things that are from 0.4 to 1.4%. There is some thought that, this kind of chronic inflammation coming and going will predispose a patient to an eventual transformation to cancer. But what do we do with that? What do we do with that because I'm sure the referrals you get are ubiquitous in terms of these lesions that come back as lichen planus. I am basically doing a biopsy to rule out dysplasia, to rule out malignancy. If you're really concerned, maybe I'll follow them up again, but I'm typically returning them back to the referral saying, came back as lichen planus, let's be aware of this, treat symptomatically if
Right.
you so desire. A lot of times they're not symptomatic, and then it's just
Yeah.
like observe, but I don't have them doing a more accelerated schedule than the every 6 month, like normal hygiene check.
Yeah, that lichen planus, that's very common. Any sort of leukoplakia dysplasias are super common. Dental offices, oral surgeons, periodontists, whatever. So those are all really cool things to know about. What about like
Mhm.
chew versus smoking? Heating the tobacco up
Sure.
versus chew and cancer risk. There was a weird time where I think they were teaching us where chew is really bad. And then there was this weird phase. I remember like even in residency, people were saying, well, chews doesn't cause cancer. It's the heating of the cigarette that causes it really. And then now it's like, I don't know, it's different again. So your thoughts on chew versus like cigarettes or vaping?
So combustible, tobacco, smoking tobacco is clearly linked to oral cavity cancer as well as a variety of others. The interesting thing about smokeless tobacco is, at least again, in my understanding of the literature, there's not robust data to say smokeless tobacco is actually causing cancer. I still don't think it's a great idea because you can see those lesions that are developing
Yeah,
in the mouth.
there's definitely cellular changes and
Yeah.
macroscopic changes going on.
So I'm never advising a patient to don't worry about chewing because I think that there's not great evidence. I still think it is causing irritation, but it's interesting. I mean, I remember being taught that as well. While, we advise against it, there's little robust evidence to suggest that it's actually linked. Now, here's an interesting thing, though, that I've personally experienced recently. With the advent of kind of more nicotine usage, especially like the Zyn pouch and the such, I have seen lesions that are at least anecdotally related to those. Like patients that put their pouch exactly in one area and then they get a smokeless tobacco keratosis-like appearance. I'm not aware of literature to support that, but I can tell you I've
Clinically,
seen
you've seen it. Yeah.
two separate. I think vaping is a bad idea in general as well. I'm not sure that it's directly related to oral cavity cancer. I just think it's bad for you. I much prefer the patients to utilize, if they need a form of nicotine, using a transdermal patch or a gum or a lozenge rather than a pouch that is causing
irritation, because we know irritation is generally not good for a lot of reasons. Yeah, very interesting. Yeah, so you guys are ridiculous. You guys do full scope, meaning orthognathic surgery, I guess TMJ, probably cancer as well, in a private practice setting, right? That's amazing.
Sure. A lot of what we're doing too is wisdom teeth.
I know. Yeah, you guys obviously, okay, yeah, you do wisdom teeth, implants. You're doing it all, and this is it's just amazing, like that you guys can fit it all in with the scope that you guys have. I think that's why I kind of wanted to have you on, because you guys do a lot. You pretty much do what you're trained to do, which is great. And most people that get out, including myself, in residency, it's amazing to have so much scope because you need to be exposed to as much as you can because you always have people helping you out. But when you get out, it's nice because people think surgeons are always super busy and crazy schedules. And part of that can be true, but it's really, you can make it how you want it. Like if you want to practice like yours, where you open it up to so many different possibilities, you can do that. If you want to work 3 days a week and just do teeth, you can do that. Or if you want to, there's so much difference in how people practice. You don't have to. Technically, you don't have to take call, at a hospital and be on call if you don't want to. So it's actually easier, I think, than dentistry, in my opinion, lifestyle wise, if you want to make it that way. It's really what you want, right?
It's a choose your own adventure. And I am a firm believer that, oral surgery is like the best job in the world. We're so lucky to get to do what we do because you really do have the freedom to kind of design it. Now, you're making choices and there are consequences to those choices. If you want to try to do this broader scope stuff, you just have to set a foundation to arrange a team around you. Like you said, if you want to do less, there's always the option to do that. But for us, we're very passionate about this. Like I feel very lucky to do what we're doing. And to a certain extent, like I'm such a nerd, I would be doing it no matter what. Like I'm like, researching this stuff in my free time.
It's not a bad thing, man. It's not a bad thing. But to like what you do is I would say most people that work probably don't like what they do. Like they don't like what they do. And it's kind of nice to know that, people actually do like what they do in a lot of cases too, which is nice. I have some quick questions for you. Like this is like rapid fire stuff. We haven't rehearsed any of these questions, obviously. So here's a quick question. So when you're looking for a parking spot, do you turn the music down in your car?
No. Am I supposed to?
No, some people do. I do that sometimes. Like you're trying to find a parking spot. It's like in the rain and downtown and you're like, you got your music on. Sometimes I just turn it down because I think that maybe that helps me find my spot better. No, you don't do anything.
I'm bumping.
Okay,
I'm like partially deaf
on one ear.
I'm just like, yeah, it's loud.
My daughter asked me that. She's like 4 and she's like, I'm like looking for a parking spot. I turn the music down. She's like, why'd you turn the music down? I'm like, I'm looking for a parking spot. I'm like, as soon as I said it, I'm like, what the hell? That doesn't make any sense. And like, so yeah, that's made me think of that. So like, what's your favorite candy? Do you even eat candy? Like, do you have a favorite?
Like a cake or a pie. But okay, if I had to
Can't really take
pick,
those anywhere though. Like if you had like candy,
I
like
don't
Mike
eat
and
a lot of
Ike's.
can.
Well, that's not a bad answer. I'm
No,
just saying.
it'd probably be like a Snickers. Like I'm
All
more of
right.
like a
So
chocolatey caramel,
you seem
probably
like more of a
something like that.
protein bar kind of guy to me. So I don't know. You got your,
Trying to.
yeah, it's not a bad thing. But yeah, what was the last concert you ever went to? Do you remember?
Ooh, so proper concert was Chris Stapleton.
Oh yeah.
Really like him. But when we were at the Nobel meeting, we saw DJ Mustard. So I don't know if you call it a concert, but it was like,
Yeah.
yeah, I had a great time. It was
Wasn't he like
amazing.
Kendrick's? Didn't he do Not Like Us? That's him, right?
Yeah,
Like
yeah.
that's his beat.
Oh yeah, yep.
All right. Yeah, he's in a lot of songs, but yeah,
Yeah.
that was his biggest one for in a while. So like, let's see here. Do you wear baseball caps ever?
Not often, no. I wear sunglasses,
All right, but if you wear a cap, do you like have the flat bill or the curved, the dad one?
curved.
Yeah, I'm
Unfortunately,
still,
Dad, I
yeah,
guess.
I can't do the flat. Do even people do flats anymore? Like, I don't even know. But this cat's killing me here. What was your, when did you have the most fun? In dental school or in med school?
Most fun?
Yeah. When was your most fun time? Dental school or med school?
Probably dental school. Those
Yeah, it's
dental
got to be
students
dental
are
school, man.
wild.
Yeah, it's
Yeah,
got to be
probably.
dental school. All right,
Those
because
dental
it's
students
four
are wild.
years. Yeah, that's you're right out of college. Like, yeah, that was med school. I thought was super boring. The people were super boring. Plus, you're only doing the clinical rotations. You're not really doing the
Well,
first couple of years
wait.
generally, unless yours is
The
different.
it's different now. The curriculum I did, well, I was doing some classes while I was I was an intern. That was really just really hard.
Yeah, I know because you have
You
to
didn't have
take your
any
step ones.
to step ones, but like we were doing some classes while working like the 80 hours and
Oh,
taking the tests on the weekends, like in a testing center. Second year was a bit more relaxed. You had much less clinical responsibility. You were kind of doing the second year, and third year was rotations. And fourth year was like a little bit, but we're also transitioning to like general surgery and some oral surgery rotations. So
yeah.
but
How
yeah,
much
you're right.
general?
Dental school is more fun.
Way more fun. Tell me, Jesus.
Yeah.
Yeah, I thought it was way more fun. I did have fun in residency though, but it was definitely not like dental school, or college, obviously. And as far as the last question, I have like dogs or cats, or does it matter? Do you like either? None?
Oh, well, I know this. I'm gonna probably get booted off because I can see your cat, but I'm
Oh, I
definitely a
don't
dog
care.
person.
I like both. I just can't have a dog because I don't want to leave it at home at work when I'm working. So like
Sure. Sure.
cats are easy that way. But yeah, I like both. But yeah, awesome. I really appreciate you coming on
Oh,
and working through the technical stuff. Last week I had a
I'm
huge
sorry. Yeah.
technical issue, so it definitely happens, man. I really appreciate it. All
Thank you
right.
so much. I appreciate it. It was fun.
Yeah, awesome. So I will get this edited out and I'll send you the final whenever it's done.